Hey, everybody. Thanks for being here. I'm really excited. Welcome to my first live stream. We're going to be talking about VA disability, mental health, things that are related to mental health. I really appreciate everybody being here and the support. Looks like we have some folks here and some questions as well. First off, I just wanted to say that as always, this is not medical or psychiatric advice in case we start talking about anything like symptoms and things like that. Other than that, everything's on the table. We'll talk about VA disability, mental health, and then things that are related to mental health that I tend to deal with. First, I guess I should do a mic check, make sure you guys can hear me and things are working. If somebody can just say yeah or something like that in the chat, that would be awesome. Awesome. Thank you. Thank you. All right. Perfect. Let's go. So first, before we get started, I just wanted to highlight Sivdiv, the legend is here. Thank you. Thank you for being here. And thanks for the support. Sivdiv, he's awesome. He's the best. And he's my inspiration for the YouTube and everything that we're doing. And obviously, I couldn't be doing the Nexus letters like we do it, without his support. So thank you, and thanks for bringing folks here as well. I really appreciate it. All right, so we're going to jump in, and we have a question already, actually, from Jan Kelsey, and she says, "Hey doc, I submitted a mental health claim for PTSD, and was approved for acute trauma stressor related disorder instead. Is there any significant physiological and psychological different impacts for secondary claims?" That's a really good question. So there's PTSD, right? Post-traumatic stress disorder. And then you have this other condition that a lot of folks get diagnosed and rated for, and that's other trauma, stressor, or related disorder. Now, in real life, this is kind of a grouping of different conditions. So this is like adjustment disorders, acute stress disorder, reactive stress. There's a few different conditions that are grouped under that. I think for the VA, what I've seen is that it's treated more like PTSD light. Okay, so that's not really what it is technically, but it's kind of treated that way. So folks who don't have the full symptoms of PTSD or not the specific time length or what have you might get that diagnosis and rating. What I've found is that a lot of times it's not the most accurate, right? The person likely has PTSD instead. So getting back to your question, so other trauma, stress, or related disorder, it doesn't have a huge impact on the secondary claims. The reason why is in this condition, you have a lot of the same symptoms, right? And when you look at the studies, so for instance, when you look at studies about irritable bowel syndrome, right, as a secondary to mental health, it's very clear that, yes, there are studies showing that PTSD causes it, but a lot of studies also show that anxiety causes it and depression causes it. So it doesn't really matter, I guess, is the point. So even with other trauma and stressor related disorder, you can still do the secondaries like IBS, migraine headaches, and a few others, that we have. So yeah, excellent question. This is a great start. All right. Hello, Fleetwood Mac and Cheese. Thanks for being here. All right. All right, next up, Cats Dogs. I love that name. Have a 50% rating for sleep apnea. Can you deny sleep study request from the VA sleep clinic? Oh, got it. What if I magically have a good night's sleep during the test? Then I will lose my rating. Yeah, that's a really good question. So you have a rating. Obviously, you have been diagnosed. You had the initial sleep study showing you have sleep apnea, and they're ordering a sleep study, right? So usually, the way that I think about it, if I were in that spot ordering a study, I'd only order it if something really changed in the person's Sorry if you hear that. That's my dog at the door. Um, I really only do that if there's a big change in the person's health, right? So they really shouldn't be doing that unless there's a big change. Like all of a sudden you lost like a ton of weight, right? 50, 60 pounds or something like that. And they want to repeat the sleep study. But um, so overall, that should be the reasoning. Now, can you deny the sleep study request? That's a good question. And I don't think there's a 100% answer on that. I think that there is a significant chance that if you deny it, right, then they're going to have an issue with that, right? And they might still end up reducing your rating or taking away the rating. That's what I worry about. Okay, myself. I'm not saying that's what's going to happen because nobody knows for sure, but that's what I would worry about. Um, I've seen some of the same thing happen, like if somebody refuses a CMP examination. Again, it's not proper, right, for them to just deny the claim based on the refusal, especially if you have a fully developed claim. But I have seen that happen. So, yeah, overall, I can't say whether to do one thing or the other, but I'd be careful about refusing. Um, in terms of magically having a good night's sleep during the test, uh, it's not too likely. Yeah, I mean, it is possible, right? Like, but I think that would only be possible if you had more like very mild sleep apnea, where your AHI number is very close to the normal range. And if you want, you can write down the AHI number if you know it. I know that's like a really specific thing, but uh, if it's very low and close to normal, then I guess you could have a night's sleep where you don't have apneic episodes. But again, I think that would be really rare overall. So fantastic question. Let me know if you have follow up to that. Um, all right. I'm just looking at these comments here. When I said for mic check, you guys responded. Thank you. There's a ton of folks. This is awesome. All right. Loud and clear. Uh, Tim Ford, it's an honor to see you this evening. Super excited for you on your first live stream. By far the best Nexus letter, Doc, hands down. Thank you so much, Tim. I really appreciate that. Yeah, I'm super excited as well. Also, a shout out to, and if he shows up here, I'll highlight his comment, but Secret Sauce, okay? Because he commented on one of my last videos, I can't remember which one, and said, hey, are you going to do a live stream? And I had thought about it in the past. It was in the back of my mind, but then I forgot or whatever. And so when he brought it up, it really pushed me to do it, So a big shout out to him. Thank you for that. And yeah, I'm really excited to do this. And thanks for the kind words. And I guess just a pause to say thank you, everybody, for your support for me and my independent medical opinions, the YouTube channel, and my course as well. It really means a lot. This has been the best thing that I've done, honestly. From what I was doing before, working in the clinics and hospitals, this is amazing. I get to work with veterans all the time, and we make big changes. And people circle back to let me know the results of different claims, and so it's awesome. So thank you. All right, Matthew Chamberlain. Yay, yeah. You're welcome, man. Thank you for the kind words. Thanks for saying that. That means a lot, and thanks for being here as well. I really appreciate it. All right. Dr. Sharma, you're an amazing, oh man, you're an amazing doctor. Because of your Nexus letter, I was recently able to get properly rated, which happens to be 100%. Yeah. Oh, well, you're very welcome. Thank you for saying that. It's all about getting what you deserve, right, as a rating. And a lot of people who come to me, they tell me about not getting that and having these CMP examinations. And again, I'm not generalizing, right? There's different types of examinations, but having those types of exams where you don't really get your rating properly done or the medical opinion properly assessed, right? And so I'm glad to do it, and I'm glad that we can make these impacts. So, B-Buck, yeah, good to see you. Good to see you as well. Another big supporter. Thank you so much. Also a big inspiration, and I really appreciate it. Thanks for being here. All right. All right, Queen Elsa. Dr. Sharma, what do we do about the changes for mental health? Good question. I'm thinking that you're talking about the new criteria, right? And so that's the criteria that was proposed to come out in April, but then it's been pushed back. I found out about that from Clay Sivdiv. Um, so it's been pushed, I believe, to August. It's still going to happen. So with that, basically, and I did a video on this, which is on the channel, and I can link over here. But we're going to roll with the changes, right? And we're going to look at the criteria through the lens that they want us to look. And really, overall, I mean, I know it's a mixed bag. The new criteria, rather than being sort of a symptom checklist uh, and then the corresponding social and occupational impairment, it's going to be a little bit different with these buckets, right? With these different categories of impairments, cognitive impairments, different things. You're going to have to grade it accordingly. And then that equals the percentage, right? So theoretically, using that, you could reach a higher percentage than what you would have normally reached before. That's not always the case, but it is possible, especially 100%, right? Because I think right now with the current criteria, it is quite challenging to reach 100% total social and occupational impairment, especially if you're still working. And also, just looking at the severity of symptoms, you have to have some pretty severe symptoms, right? That's not going to be the case any longer. It's going to be, I hesitate to say easier, but it's going to be a little bit more doable to get to 100%. What I worry about, and I think a lot of people worry about, is whether or not that's going to be judged right. So with CMP exams, where you have to do a very in-depth exam in general in psychiatry and mental health, but especially with the new criteria, you're really going to have to go down and look at the different levels of impairment. And you got to sit and think for a little bit and say, what level is this impairment at? And then you grade it accordingly. That takes a little bit of time. And now, again, like I said before, I'm not generalizing on CMP examinations. However, from what I have been told by, at this point, hundreds of veterans, is that they don't get comprehensive exams. Okay. That's not everybody, right? So I've had folks who've had excellent CMP examinations, very comprehensive, and they go through everything and they get the right rating. It's great. But I worry about the other side, right? And I worry that those CMP exams are not going to capture the full extent of the mental illness, right? Pretty much. A lot of people tell me their psychiatric CMP examination was 5 minutes, right? Some people will tell me, I got there at 1 p.m. I was in my car at 1:08 p.m., right? Which is, that should never be the case. You cannot do a mental health comprehensive evaluation in less than 30 minutes, in my opinion. And 30 is on the short side, right? If things are straightforward and you've looked at all the evidence ahead of time. So that's only when it's straightforward. Otherwise, it's an hour. Sometimes it can be longer, right, as well. So we're going to roll with it, and we just have to make sure to understand the new criteria really well. And, we're going to keep tracking it. So excellent question. If I'm on a medication for depression, does the VA have a reason to reduce the rating? Really good question. So there's two sides to this. There's the current criteria, right? And then there's the new criteria. Now, I will say overall, if you're on a medication for depression, it might be, hopefully, it might be helping your symptoms, right? It's making your mood improved, it's lowering your anxiety, things like that. But it's very likely that you're still struggling with symptoms. A lot of folks tend to, right? Not everybody. There are some folks where they get on a medication for depression and it's wonderful. Their depression goes into full remission. That's a little bit different. But just because you're on a medication, that does not allow them to reduce the rating. They still have to look at the severity of the symptoms, okay? And that comes from the evidence, right? So the notes that you have at the VA or with your civilian provider, and at the CMP exam or whatever examination you do to judge your rating. Okay, so they can't automatically reduce it. The new criteria does say that if a medication ameliorates, right? So if a medication improves the symptoms, right? Then the rating can be lower, right? Based on that. At the same time, you also have to take into account other things like side effects, right? So with a lot of antidepressants, and I wish this was not true. I wish that we had a perfect medication out there, but with a lot of antidepressants, people have what weight gain, right? And then for men, ED, right? And then or diminished libido in women, and both men and women. So there are side effects, and you have to document those side effects because those matter as well, and those contribute to the symptoms, and that those should go under the symptoms and the evaluation, and look at the impairments as well. So because that is some degree of social impairment, right? If somebody has ED or something's interfering with that part of their lives. So anyway, so they can't automatically reduce it. It really depends on each case, and you have to look at the individual symptoms. But fantastic question, and we're going to see how this plays out with the new criteria as well. Outlaw, yeah, good to see you as well. Thank you for being here. Thank you for the support. I appreciate it. Okay, as sure as the sun rises, the VA notified my uncle of an upcoming CMP exam after requesting to not have one. Yeah, with your IMO Nexus submitted. Yeah. So that's the thing, right? I mean, so when you're submitting a fully developed claim, right, where you're submitting a medical opinion, right? So independent medical opinion / Nexus letter with it, and a DBQ, and along with your other evidence, you're submitting a fully developed claim, and you're submitting a fully actionable medical opinion and DBQ. And according to VA regulations, right, which I can pull up, they need to make a decision based on that, right? And they're not supposed to technically order a CMP exam. CMP exam is unnecessary at that point, and in my view, is a waste of money as well. So, and time, right, for the veteran to go travel somewhere or connect with someone. So, yeah, again, this should not happen, right? And a lot of veterans I work with, I give them the medical opinion and DBQ, and they get approved without a CMP exam. It's great. And then other veterans, they don't. Okay. And there's a percentage of that. I notice. Okay. I notice a percentage where, and it has changed over time, because as I've kind of refined my Nexus letters and DBQs and how I fill them out. And it's hard to say. I can't give you an exact number because not everybody comes back and full circle to tell me that, what happened with the claim. But I can say it's about 60 to 70% on the success rate without a CMP examination, and then the rest who get ordered unnecessary examinations. I wish that wasn't the case. But I usually try to prepare people for both outcomes. All right. And let me know if you have questions on that. I have SI. Do I have to tell them every time I have an intake assessment? Will I get in trouble for false statements because I hate telling everybody? No, that's a great question. So with this, right, suicidal ideation, this is a big topic. And I think that some providers don't understand it completely. All right. So in the VA criteria, when it says suicidal ideation on the DBQ, right, that doesn't mean that that person has suicidal ideation all the time, right? And it is more on the rare side for somebody to have SI all the time, like every single minute of every single day. Okay, that does happen. It can happen, yes, but that is more rare. So what's more common is that when folks are in especially low moods and very depressive episodes, that's when the SI comes out. This can come out after an argument with a spouse. It can come out after a death of a loved one, or some issue at work, right, where you're getting written up or audited or something. And then the SI will come out at that point. So it's not there all the time. Okay. And the VA criteria, it does not suggest, or it does not require that it has to be there at all times, but it has to be significant. And so you don't have to talk about it at each intake assessment. I would say periodically, definitely discuss it. And you can say at some of the appointments when you're going, you can say, listen, 2 weeks ago, X, Y, and Z happened, and I had some thoughts that life's not worth living anymore, or whatever those thoughts are, and then they resolved, but it was still difficult, right? And I don't like feeling that way, etc. And so you can discuss it, but you don't have to discuss it at every visit, and it depends on how you're feeling as well. And there's different levels of it, and I think that, just to talk about this too, a lot of folks are hesitant talking about it, especially within the VA system. And again, I'm not generalizing, but I think that there is a concern. And I did a video on this recently on the improper use of the Baker Act in a specific case. And it sounds like this happens. I'm not going to say very commonly, but it happens from time to time, where if you do discuss suicidal thoughts, that there is the chance of this Baker Act happening. Now, that shouldn't be a reason to not discuss it, okay? But just to understand, that's why people feel hesitant, and it's understandable. And that's why it's good that case came to light, that Marine and what happened. And I'm glad it came to light so that things can change within the VA system. So, all right. Based on a previous question I had for you, do you believe the VBA will consider delayed onset of stressor-related PTSD many years after service, especially if one didn't seek treatment over the years? Oh, yeah. Very good question. And thanks for bringing this up on the last, or one of the last videos, and then here. And I think I'm going to do a video on this topic, this delayed onset of PTSD. This is very common, right? So you can have a stressor event in the military when you're, doing your job, or when you're deployed, whatever it is. And then for a while, you can feel okay. And then there can be a delayed onset, sometimes months, sometimes years later. And so, yes, they will. And they will consider delayed onset PTSD, okay, after a stressor, which is good for veterans. How do I know that? It's because I've helped people with that, basically. And I can tell you, so, I work with veterans directly on the medical opinions, and then I work with a few law firms as well. And with the law firms particularly, they send me a lot of complicated cases, right? And those cases tend to be a little bit older as well. And so I've helped a lot of veterans, Vietnam veterans, get their service connection, based on these stressors that occurred many years ago. And I think most of the time there are years in between the stressor and when the person initially seeks help, especially in the Vietnam veterans. I mean, there was no way people were seeking help back then. And then especially, even now, we think, and it is true, that the stigma is a little less on mental health, but the block is still there, especially in veterans. And so a lot of folks will not seek care for years and years. So this can absolutely still be done. And medical evidence is key, right? So seeking treatment, going to get assessed, going to therapy, okay? Going for medication management if you're comfortable with it, if you want to do that, and if it's required, okay? If it's required for your condition, it is not mandatory, right? So a lot of veterans will tell me, I don't want to go and just get put on a bunch of meds, okay? This happened to my friend, it wasn't good. You don't have to do that. When you go, you can get assessed, and you can say, listen, doc, I want to go to therapy. I want to try CBT or something, right? Cognitive behavioral therapy or something like that. I don't want to do medications. If you don't want to do it, you don't have to do it. Okay. they are not able to force you. And you can definitely advocate for yourself and say, no, I'm not doing it. It's not required. All right. So, but yeah, medical evidence and the delayed stressor event and delayed PTSD absolutely can be done. Fantastic question. And I wrote this down in my Google Keep as one of my topics for a future video. Wigwam Jones. Just wanted to say hello. Really enjoy your videos. I found out about your channel from Clay. Awesome. Yep. Clay is amazing, man. And thank you. Thanks for watching the videos. And I think I know your username on the comments and the videos. So I really appreciate it. It means a lot. All right. Scrap Guy. Hello. Hello. Welcome. Good evening, Doc. What actions do you recommend for veterans? Sorry, this is OJ Wild. I forgot to read his name. What actions do you recommend for veterans who have actionable and sufficient DBQ completed by you or others, but are still but are still scheduled for CMP exams? Yeah, we were talking about this, and so while I can't tell you what to do, right? I'm not an accredited agent, but what I can say is what I have seen happen. You submit everything correctly. You do everything by the book. You even put in a personal statement where you write down the VA regulations and CFR that say that if you submit a fully actionable DBQ and IMO and a fully developed claim, that it should be adjudicated according to that evidence, but you still get scheduled. And what I have seen is folks who refuse to go to the examination. Sometimes the claim can be denied based on their refusal. And then the decision letter comes in, and the decision letter says, the claim was denied and you refuse to attend an exam. Now, when I see that, I also see multiple possibilities in another area. So in the evidence reviewed section, sometimes my medical opinion and DBQ will not be listed in the evidence section, right? It's mind-boggling. You did it right. You submitted everything, but my evidence is not there. They did not consider my medical opinion. They did not consider my DBQ when making their claim decision, which is not right. So then you have to go back, maybe do a higher level review, right? And actually get that evidence looked at. By the way, if you do a higher level review, always do informal conference so that you can verbalize to that human being, right, on the phone that you submitted a fully actionable DBQ IMO and fully developed claim. So that's what I see. Another thing sometimes I see is in the evidence reviewed section, it'll say Dr. Prashant Sharma treatment records, right? And I do not do treatment, right, with these claims. They are not treatment records. They are independent medical opinions and DBQs. Why are they labeling them as treatment records? That's not proper. And again, when you read the narrative, my medical opinion and DBQ are not there. And they only have the VA CMP examiner's opinion there, right? So, which again is not right. So again, that requires a higher level review because the evidence was not reviewed appropriately. So, so overall, I can't say whether to do one thing or the other, but that is what I've seen from folks who refuse to attend, and then what you have to do afterwards. So it's a gamble, right? You could get denied, and then you'd have to do a higher level review to get them to really look at the evidence, or it could get approved, okay, based on the fact that you had everything there. I hope that was helpful, and let me know if you have other questions. Jan Kelsey, by the way, Doc, you're one of the best medical advocates on YouTube for veterans. Oh, thank you so much. Thank you. That means a lot. You guys, you're the best. And I'm really glad, I started doing this, and especially the channel. One of my good friends from medical school, he's not a veteran, but he's a huge supporter of veterans, right? And when I told him about this, it was in the beginning of the channel, and he said, dude, you have to do this, right? You have to continue. I don't see anybody else doing this. I don't see any other physician doing this. You have to do it because you can get the information to them. So that was another big inspiration. So thank you to him as well. All right. All right. I'm going to take a sip of water here. All right. Next up. And thank you again for everybody being here. Truth Scout, if you already retired in your 70s, can you still put in a claim for anxiety? There will be no occupational issues because of retirement. However, the social issues are still there. Excellent question. Yes, you can absolutely put in a claim for anxiety, and you should, with the medical evidence and corroborating evidence. So how that works, and I see plenty of folks with this as well, folks who are in their 60s, 70s, 80s, and who are retired. So you look at the symptoms, you look at the social impairments, and then what I do is I go and I look at occupational impairments, looking back at the last job that you had, okay? So let's say you were working last at age 64, okay? Then we go back in time, right? And we talk about what duties you had at that time, okay? So let's say you had a job where you sat at a computer and you did administrative work. So then we take those duties and we say, how would your current symptoms interfere with those duties, okay? And then we look at it through that lens. So if you have anxiety, then is the anxiety so severe that it disrupts your concentration? You can't concentrate on administrative tasks. And this happens to you in your regular daily life, in your personal life. And so that's how it translates into the occupational side. Do you get irritable because of your anxiety? And the irritability would interfere with your professional relationships, right? And so that's what I do, and that's what we should do. We should look at it through the lens of, could you go back to work? That's really the best question to ask. Could you go back to work hypothetically with your symptoms, right? And then we get the occupational impairments from there. It's not as good as if you're still working, obviously, but it still works, and it works really well with the claims and evaluations. Thank you. Excellent question. Carlos Martinez, I have a rating for 50% generalized anxiety disorder. I'm wondering what could be possible mental health related secondaries or not poke the bear and focus on physical claims so generalized anxiety disorder. With anxiety, there's a lot of things that can happen secondary. And that includes things like irritable bowel syndrome. Okay, there's a big brain-gut connection. All right, we have more neurons in our gut than a cat has in its brain. Okay, so it's a lot, and we have a lot of serotonin receptors in our gut. So a lot of folks, when they get anxious, they feel it in their gut. They feel butterflies in the stomach. They feel abdominal cramping. They feel maybe some loose stools. Okay, stool urgency, which is having to rush to the bathroom, right? Some other people, they can get constipated, right? And they can get severe constipation and changes in the form of their stool and all this stuff. Or it can go back and forth where you have diarrhea and constipation, right? And it cycles back and forth. So that's a big one. And the brain-gut connection is very well known. Okay. And there are brain gut clinics, okay, at university hospitals. So it's very well known. So that's a big one. Headaches is another big one. So migraine headaches, tension headaches, those can definitely develop from anxiety. They've done a lot of studies on that. They've shown that anxiety can cause these headaches. They've looked at blood flow in the brain in folks who have anxiety, depression, PTSD, and they've looked at blood flow in the brain of people who have migraines, and they found some common blood flow patterns. So there's some other stuff there that's very interesting as well. So that's another one. There's a lot, really. Anxiety can sometimes cause hypertension, right? So high blood pressure, increased heart rate. Um, there's definitely a lot, and you can email me and ask more if you have specific questions. In terms of not poking the bear, that's a little bit harder to answer because it really just depends, right? Often it depends on which rater you get, right? Who reviews your package. But I wouldn't, if you have a condition, right, and it's bothering you and you have medical visits and medical evidence, I wouldn't let that stop me, right? Uh, because all of these things are connected, the things that I talked about. Okay. And you should still focus on the physical claims too. Great question. Gray Smith, pharmaceutical question: trazodone and duloxetine, can they be taken together? MDD diagnosis and now sleep apnea test scheduled. Don't know what that will entail. Okay, so with the first question, this is not medical or psychiatric advice, so that one I can't answer. Okay, because it's your specific case, so I can't say for you. Okay, and the reason for that is you could be on other medications as well. Okay, what I will tell you is that I have. Before I started doing these Nexus letters and evaluations full time, I used to do treatment, and I have had plenty of folks on both of those medications together. So again, in your case, it might be different because you have to look at your full medication list. But I've certainly prescribed both medications to folks. Major depressive disorder diagnosis and now sleep apnea test scheduled. Yeah, so with a sleep apnea test, there's different types of tests. There's in-lab tests where they hook you up to all these different things, and you have to sleep in the lab, which can be difficult, I think, for some folks, and they monitor you. Or it can be a home sleep study where they send you a kit or they send you home with a kit, and you hook it up yourself, and it monitors you. The in-lab sleep study is always the most accurate, right? So if a home sleep study does not show sleep apnea, there is a chance of still having it, right? So the in-lab sleep study is the most accurate. The job of the sleep study is to measure the number of apneic episodes you have. Apneic episodes are episodes of gasping or choking at night, right? So that's when you're sleeping, and if you have sleep apnea, it's that kind of thing, right? And some people can have that and they'll cough, right? And so that's what it's supposed to measure. It's also supposed to measure your oxygenation, right? So your oxygen saturation, right? And what it measures that. And with apneic episodes, the danger or the concern is that the oxygenation is not there, and then you have a lot of problems related to that. And untreated sleep apnea can result in a lot of issues. It can result in hypertension. It can result in heart disease, obviously poor concentration during the day, irritability, daytime sleepiness, falling asleep, things like that. So it's definitely important to get it checked out. Excellent question. Charles Bender. Hi, Dr. Sharma. Why do you think your IMOs and DBQs are so much superior to any other providers? Thank you. Thanks for saying that. So, yeah, this is a good question. So, when I started doing these, in the very beginning, I started working with law firms. Okay. This is way in the beginning. This is before me and Clay connected. Okay. And I was still learning the ropes at this point. And I found out about these medical opinions and DBQs, and I said, let me try this out, because I realized there's not many people on the side of the veterans, right? And I said, let me try this out where I can work with a law firm who's trying to help a veteran, and they've vetted the records already. Okay. So in that process, and I still work with these law firms, I was able to learn from them how to structure my medical opinions. And then I put my own spin on it as well. And I took that same formula and I brought it to direct working with veterans as well, because it shouldn't be reserved for just one area, right? And then I ended up seeing other Nexus letters from different providers, and I noticed how they are not comprehensive, right? And they might be 2 pages long, and it seems like it was a fill in the blank questionnaire, right? And so the reason why I think is that it is comprehensive, and I think, and this is a bit of, as the kids say, like self glazing, right? Like, so I'm like complimenting myself, but I think it's because it's it looks at every aspect of the veteran and in the evidence. So when you look at my Nexus letters, I have a couple of different sections, right? And every section has a purpose. You have the introduction, which is self-explanatory. You have the final diagnoses. Okay, that's important because they have to know what I'm diagnosing the person with. I have expert qualifications, right? The reason why I put that there is probative value. Okay, what is the probative value of this medical opinion when compared to another medical opinion? Probative value has all of these things incorporated, including credentials, right? Is the person a board certified psychiatrist? Is the person a board certified urologist, if it's something related to that? Or are they a different level? Are they a nurse practitioner or a physician assistant or psychologist, whatever it is? So that is there, and it's all right up front. And then I do a summary where the summary is really quick, right? So it's only like a few paragraphs, and it tells them exactly what I think and what my professional opinion is. And then it's the more lengthier part. It's the evidence analysis. The evidence analysis, I actually include snippets, summaries from different notes throughout the medical record of the veteran. And these snippets are important because I purposely include them because they work towards proving the case. Okay, and as we go through the snippets, we see those are pieces of evidence, right, that go towards the claim and the condition. And I put that down there. It also tells the VA that I actually read the records, right? I can't just put, oh, I read, I have reviewed the VA medical records, period. I can't just put that, right? Because it won't convey to them that I actually read it. So that's the other thing. And then the evaluation of the veteran. So 99% of the time, I see the veteran. I do a video visit with them. Okay. And then that's where I put the subjective information that the veteran tells me during the visit. That's also very important. The only times I don't do that is sometimes with law firm cases when the veteran is deceased, right? It's like a DIC claim or something like that. So then I have the subjective component. Then I have the scientific literature section. That's where I have scientific evidence. That's where I have the specific peer-reviewed scientific studies that I cite for that case. And then I have the summary rationale where I apply everything, including the scientific evidence, to that individual person's case. So that was a very long answer to your short question, but I think that might be why. It's everything together, and that equals the high probative value. And I'm really thankful for the response overall from the VA on these medical opinions. Yeah, thank you for the question. All right, Moisey. Thank you for being here, by the way, and your support. Doc, I've been denied twice for mental health due to service connection, didn't even get a CMP exam. But we are appealing with higher level review with informal conference. What are things I can focus on? Yes. Great. Excellent job on doing the HLR with informal conference. Okay. Now, I do remember your case, but I'm not going to, discuss obviously any details. But what you want to focus on is what was missed. Okay. You want to focus on the issues that were still there. So, for instance, you didn't get a CMP exam, okay, and you were still denied. All right. So that also doesn't make sense because you had a positive medical opinion, and then there was no opposing medical opinion. So did they even consider the positive medical opinion, or what happened, right? So you want to mention that. You want to discuss how the condition is connected to service, right? And you want to discuss um, some of the points from your case. Okay. Now, I don't want to say too many specifics, so email me ahead of, later if you want, and I can give some more suggestions. Okay. All right. Next up, King. Thank you, Doc. You're welcome, and thank you for being here. I really appreciate it. Thanks for the support. Course. Oh, yeah. So I have a course for veterans who have PTSD, anxiety, irritability. I'll drop it into the comments. I think that's how you do it. This is my first live stream, guys, so I hope I'm doing it right. I just put it in the comments, so you can check it out. Basically, I go through what PTSD, what anxiety is, and how to deal with them, right? The tools that you can use, and I actually teach you the tools. What types of therapy you can pursue later if you want to take it up to the next step, the next level. And then I talk about so PTSD, anxiety, depression, irritability, managing irritability. That's a big one, right? So a lot of veterans struggle with irritability. And then I ended off with my favorite module, which is finding purpose and meaning in life, okay, which is really important to everybody, okay, not only veterans, but with veterans specifically, I feel like we sometimes have a loss of identity or a loss of purpose after getting out of the military, or we have trouble fitting in. So that module is also really important, and I'm really proud of that one too. But yeah, check out the course if you'd like. Dan Ringman. Thank you, doctor, for taking the time for us today. You're welcome. Yeah, thanks for being here. Thanks for the support. You guys are amazing. I am endlessly grateful. Okay. Let me tell you, I was very stressed at my other jobs. Okay. Hospital, clinic, these big corporations and clinics, they want you to see a lot of patients. Okay. And it gets really difficult. Now, I went into these independent medical opinions, and it has been amazing. I've been able to work with veterans on a daily basis. I've been able to see veterans slowly, okay? See one person at a time, work on their case, really know the case inside out. And it's been really rewarding in so many different ways. And then people tell me about the impacts as well. So I'm just really grateful to you guys. All right, green light. Just got service connected for PTSD, only rated at 30%. Was thinking about seeing a private doctor to get evaluated. Is this something I can do with you? Sure, yeah. So with getting service connected, so good job on getting service connected first, and you got 30%. It sounds like you feel like you're underrated, right? So the real important thing is the DBQ, okay? Whichever private doctor you see to get evaluated, they really ideally should fill out the DBQ. That's the big thing, because the DBQ tells us the severity of the rating. Now, yes, I can work on this with you, absolutely. What I do with DBQs is, because the DBQs, the fields, they don't allow, there's not a lot of space in those DBQ fields, right, on the PDF. So with the DBQ, I include an attachment with rating increases where I give more information. I have to do that because I can't condense everything into like 2 paragraphs, right? I'm not able to do that, and we shouldn't do that as psychiatrists, in my opinion. But the real important thing is the DBQ, because that goes through the rating criteria, and it has the specific checkboxes and verbiage. Social and occupational impairment with deficiencies in most areas of life, including work, family relations, judgment, thinking, and mood. Whatever it is, it has to be in that verbiage. So yes, I can work on this with you, and the most important thing is that DBQ. Jamie Lee, Your course is great. Thanks, doc. Oh man, thank you. Thank you for taking the course, right? It means a lot to me. That course, it's like, it's one of those things, those passion projects, uh, I really, wanted to make it, and I put some of myself into that course. As you saw, I talk about some of my own struggles in a short way. I don't bog you guys down, but it's really important because we all do struggle as veterans at one point or another. And, you know, we as psychiatrists, I want to be, um, you know, I want to be able to talk about that. Okay. I'm not saying it's, I'm going to talk about everything about my personal life, but I want to talk about my struggles so you feel and you see, okay, even Doc, right? Even Doc had this issue going on, and this is what he did. Okay, let's go. Let's keep doing it. Let's keep fighting. Let's keep conquering these struggles. So anyway, yeah, thank you for taking the course. All right. Hello. Yeah, thanks for being here. Thanks for the support. I see your comments on my other videos and things as well. I really appreciate it. All right. All right. Prof. Hayes, can you recommend any agency that helps veterans file claims and appealing denied decisions? Keep up the good work. Thank you. You're very welcome. And thanks for the kind words as well. It really means a lot. Yeah. So I work with several different, always, I recommend accredited VA claims agents and such. So there's really different ones, and there are a lot of different options. I think the two ones that I think of right off the bat is Hill and Ponton, right? They're a very large firm. I work with them. They are wonderful. Okay, let me tell you, they are comprehensive. They are very thorough. They are fantastic. Okay, and I've seen them do wonderful things on cases, and that's a larger firm. Then I also more locally work with Andrew Gross. Okay, Andy Gross, and his law firm here in Baltimore, Maryland. I'm based in Baltimore. He is fantastic, phenomenal. I'm telling you. And one thing to mention. So you can Google him, right? Andrew Gross, and his law firm name changed to Guide on Law. Okay, so just keep that in mind. It might redirect you to Guide on Law. So he's really great. But yeah, so those are some of the suggestions that I would have. And let me know if you need specific contact information for them. Just shoot me an email. Does Nexus Letter help for increased rating? How difficult is it to get increased rating for depression from 30 to 70%? Because my symptoms and evidence points towards 50 to 70. Yeah. Excellent question. So, so technically, a Nexus letter implies that it is a letter showing a nexus or connection between service and the condition, right? And that's an independent medical opinion. I would recommend getting a DBQ for the increased rating, if possible. I know it's very difficult to get one at times. A Nexus letter does help with that. So when I do a DBQ, I include a medical opinion attachment with it, with more information. Okay. So if the rater just wants to look at the DBQ and they just want to look at the criteria, boom, they're done. Fine. If they want to look at more information, they can look at the medical opinion. All right. How difficult is it to get increased rating from 30 to 70? That really depends, right? And it depends on individual symptoms and your level of social and occupational impairment. Excuse me. So I know I'm not answering it directly, but it depends. And there's different areas, right? So, and you can look this up online. Hill and Ponton also has it actually on their website, is the rating criteria and different symptoms. And you can look at that, and you can look at the VA CFR as well, and you can see which symptoms end where. I will say one thing, and you specifically mentioned my symptoms point towards 50 or 70, and I just thought of this. There is no requirement to have suicidal ideation, SI, to get 70%, technically, okay? having it seems to get 70% more quickly, I guess I could say, but it's not required to have that. I've helped plenty of folks get to 70% who don't have SI. Okay, so just wanted to mention that because I think sometimes that's a misconception. So I would recommend DBQ, and if you can't get a DBQ, sure, a medical opinion that states your symptoms. But if you do get a medical opinion and not a DBQ, just it would be great if they can list the symptoms from the DBQ as well. So I know this is really difficult, but um, thank you. Great question. Here you go. Yeah, yeah. So yeah, thank you for the support. You comment on a lot of my videos. I appreciate it. And you're very welcome. Yeah, and thank you for the kind words. It means a lot. Can sleep apnea be secondary to major depressive disorder with psychotic features? This is Kings. Excellent. A very good question. That's great. So obstructive sleep apnea, yes, it can be secondary to major depressive disorder with psychotic features. However, you have to look at the case and if it fits. So depression itself does not directly cause sleep apnea, right? Because obstructive sleep apnea is a structural abnormality here, right, in the throat. However, major depressive disorder can cause other things. Major depressive disorder can cause increased appetite, binge eating, weight gain, okay, and that can cause sleep apnea. Now, this is very important. You said with psychotic features. So there might be some hallucinations, some delusions, something else, and you might be on antipsychotic medication. And this is where medication comes in. Antipsychotic medications, they are notorious for weight gain. I mean, some of the newer ones aren't, but the ones that typically people get prescribed are notorious. They cause so much weight gain, among other side effects. So that can be very powerful to go towards a sleep apnea rating and evaluation. Another thing I wanted to mention is antidepressants. So 2021 and 2022 studies came out about antidepressants, SSRIs, okay, specifically, that can cause obstructive sleep apnea, right? And this is even when those medications do not cause weight gain, they can still cause sleep apnea. Crazy, right? So even being on an antidepressant for depression without psychotic features, that can still cause sleep apnea. So I hope that answers the question. It depends on the case. You always have to look and see, let me look at this case and really try to figure out, is there a connection here? Okay. And you have to look at all the different lenses. Okay. That's one of my biggest gripes with CMP exams is they're not looking at the different ways that things can be connected. Okay. And if the evidence is there for the connection, you have to find it, right? You have to see it, especially when it's clear. So excellent question. Fantastic. Cats, dogs. All right. Follow up. Excellent. Diagnosed and rated for sleep apnea with 100% PNT. I cannot tolerate the CPAP, so I went to the VA hospital to make a MAD. Shoot. What is an MAD? I'm probably blanking here. They want to follow up with a sleep study. Yeah. So diagnosed and rated with sleep apnea. You can't tolerate the CPAP. So I guess the question is, has anything changed significantly in your health? Have you lost a lot of weight? Have you gotten off certain medications? Things like that. That could influence the results of the sleep study. But overall, if you're not able to tolerate the CPAP, that means you haven't been able to use it, right? So it hasn't been really helping your sleep apnea. So I would still get that done. And then I'll look for your comment in case you tell me what MAD is. And I apologize. It's probably something I should know, but All right, Charles Bender, what what are you most excited about in the field of psychiatry? How do you feel about AI like ChatGPT? Ooh, it's a very good question. Yeah. What am I most excited by? Okay. Uh, is this has to be done, with a professional and a doctor and a therapist and in the right format. But psychedelics, I find psychedelics very interesting, fascinating. A lot of veterans have had improvement in their PTSD, depression, anxiety with psychedelics. It is amazing, some of the results. Okay. And some of the studies are very promising. There are folks who will take a psilocybin microdose, okay, and they have remission. They have improvement in their symptoms, and it is still there for 6 months, and they just have to come back and do another microdose, okay. And I'm not saying that happens every time, okay, and there are some folks who shouldn't do psychedelics at all, but that is what I'm most excited about because psychedelics allow your mind to change. Okay. They open up your mind in a way that you can finally defeat some of these inner demons. Okay. That's what I love about them. I've seen severe cases of OCD be transformed, severe PTSD, other things be transformed by psychedelics. Again, it has to be done officially, but I'm very excited about that. ChatGPT. I think that AI tools like ChatGPT can be amazing in psychiatry, in mental health, for physicians. But I'll say the negative first and then the positives. So HIPAA. Nobody should be putting HIPAA information into ChatGPT. You should be looking for HIPAA-approved tools that incorporate AI, and there are AI tools that are HIPAA compliant, and they're encrypted and they're secure. So hopefully no providers are putting in HIPAA information into ChatGPT because that's not secure. But getting back to the promising parts, I think it's very promising overall, especially for things that are not HIPAA. So, for instance, as a physician, I have access to Doximity. Okay, it's a website, and it has an AI tool in it that scrubs peer-reviewed scientific journals, and it gives you results. So this has been mind-blowing. Like I've used this to research. I still do my own searches because I don't fully trust it, but that's my own thing. I type in a question. Okay, I say, "Hey, give me the latest studies showing how depression and anxiety can aggravate shingles." Okay, because I have a veteran who said, my shingles is made significantly worse by my X, Y, and Z, right? And I type that in, and boom, it gives me a list, and it gives me the links to the journals, and it gives me descriptions. Okay, I still go and read the journals because, again, I don't fully trust it, but it's been amazing. Okay, yeah, it's fantastic. So I'm super excited, and I'm probably speaking too quickly right now when talking about these things and nerding out. But thanks for asking this. This is awesome. I should do a video on this just for fun. Outlaw, how can we donate, Doc? Oh man, thank you. That means a lot. I'm gonna figure that out. Uh, I don't know exactly how to do it, but I'm gonna figure that out. Okay. Uh, I have an idea in mind for the channel. So I work with different, organizations, and a few times a month. It depends. It depends on the need. I'll do like pro bono cases, like no fee, for people who are really in a bad spot. And I was thinking maybe I can do donations on the channel, and then I can use that to pay for some of these. Not the pro bono ones, but some other evaluations that would be covered by the donations, if that makes sense. And then I was also thinking about doing like a giveaway, a Nexus letter giveaway, and then I can use the donations as well. So those are some of my thoughts. I don't have a button for it right now, but I'll figure it out. Thank you for asking. Happy Gilmore. Hello, Dr. Sharma. Thank you for all you've did for me and the veterans, and you have helped. Thank you for saying that. That means a lot. And I think I remember your username either on Clay's videos or my. So thank you for saying that. Thank you for being here and watching. It means a lot. Scrap Guy, what's your thoughts on someone with somatic symptom disorder, primarily pain, with depression, anxiety symptoms? Yeah, great question. So somatic symptom disorder, there's different, uh, facets to it, but basically it is being very focused on physical pain and sensations in the body and spending a lot of time trying to manage those physical sensations. Okay. Like you said, pain, depression, anxiety. This is significant because I think that a lot of veterans have these issues, these musculoskeletal issues, pain. Okay. This comes from high impact activity. Okay. This comes from ruck marches and humps and whatever the name is for your branch, where you're marching long distances and you're carrying these heavy packs. And so there's a lot of this high impact activity that can result in these musculoskeletal issues, and that can result in somatic symptom disorder. Okay. Now, there's another thing to that. There's also depression secondary to chronic pain, which is similar to somatic symptom disorder, but different. It might not have all the all the features of being too focused on physical sensations, but there still is depression coming from the chronic pain. Okay, I did a video on this as well, where basically your mobility is diminished. Okay, because of chronic pain. You can't pick up your kids. You can't run or walk as you used to. Things like that. And that all contributes, and that can all cause depression and anxiety. So, excellent question. Queen Elsa, can you speak on migraine secondary to PTSD? 100%. So, the scientific literature on PTSD causing migraines is very strong, very. You have a lot of these studies showing where you have these large groups of patients with PTSD and high percentages of migraine headaches when compared to the general population and controls. And this has to do with stress. This has to do with anxiety. This has to do with insomnia, right? A lot of people with PTSD, their fight or flight center, the amygdala, is hyperactive even at night. It causes you to lose sleep. You might have nightmares, other things. And insomnia can also result in migraine headaches. Okay, when it's over time, and so absolutely, the evidence is very strong for that. And a lot of people will tell me, Doc, it's like clockwork. When my PTSD gets aggravated, right? Like when I get a trigger, like I watch, some news report of some war happening somewhere or whatever it is, and then I get a migraine the next day. It's like clockwork. So I think that absolutely happens, and there's a lot of scientific evidence for that. Charles Bender, with so many overlapping symptoms in the field of mental health, how do you determine an accurate diagnosis? For example, how would you rule out myalgic encephalitis or chronic fatigue syndrome from psychiatric disorder? Oh man, excellent question. Another very, very, very good question. So chronic fatigue syndrome is a diagnosis of exclusion. Okay, so what that means is that you have to rule out other causes of fatigue and similar symptoms. So let's say I have somebody with PTSD and they also have chronic fatigue and they have joint pains, muscle aches and weakness. They have swelling in the lymph nodes here. They have constant sore throats, even though they don't have viruses, right? I'm telling you all the symptoms of chronic fatigue syndrome. I look at that and I say, okay, this is interesting. So these don't seem like they're just coming from the depression, right? So then you have to order blood tests to rule out other causes of fatigue. So you want to order a CBC to rule out anemia, Okay, so because anemia can cause fatigue and chronic fatigue-like symptoms. You want to rule out liver conditions. You want to rule out low testosterone in men. You want to rule out low vitamin levels. Okay, you want to rule out hypothyroidism. Okay, so you want to get a thyroid, a TSH level, and so you want to do that. You want to rule out the other causes of fatigue. If somebody has sleep apnea, you want to make sure they're using CPAP, okay, and that the sleep apnea is treated, but they still have all of these symptoms. So you rule out other potential causes. Also, because you don't want to miss something, right? So if somebody has chronic fatigue, you don't want to miss something, something really bad, right? Like cancer or something like that. So you want to rule out other potential causes. So that's what I would do. And it's very systematic. And it's a great question because there are a lot of overlapping symptoms in mental health. Dennis Whitecamp, PTSD denied. Sorry to hear that. Diagnosed with MDD with anxious distress, not service connected, no rating and no rationale. Filed higher level review, received duty to assist error, and scheduled for new CMP. Any thoughts on why MDD wasn't rated the first time? Very good question. I'd probably have to look at the specifics. It's hard to say. I'm curious about what the decision letter might say. Okay, I'm curious about what rationale there was to deny and what was missing. I'm curious about what the favorable findings were on the decision letter. And then I could probably answer a little bit more. It sounds like you were diagnosed, but it wasn't connected. So probably a favorable finding is that you were diagnosed with a disability, MDD, with anxious distress. I'm guessing that there was no nexus established. There was no connection. So the question is, how is that connected to military service? I'm guessing a little bit here, right? But that would be my educated guess, is that there's a nexus missing. And you want to look at that and see how that could be helped, basically. And of course I can help with that, but yeah, it sounds like a nexus. You can tell me more or email me. JC, how do they know if you are cured mentally versus masking? How can they reduce if I were to go off meds? Oh, yeah. No. Don't go off meds. All right. Yeah. Great question. How do they know if you're cured mentally versus masking? So that has to do with medical evidence, right? Progress notes in the treatment record, and your mental status exam. I'll explain. So looking at the visits, if you're going to visits regularly, you're getting medications refilled, obviously this thing is still bothering you, whatever the condition is. And so, it's still there. And so, and then the mental status exam. The mental status exam is how we look at someone as a psychiatrist, and we try to figure out if they're depressed or not, okay? And now I'm simplifying that a little bit. And that involves looking at different features, looking at eye contact. How much is the person making eye contact? That involves, how they're dressed, how they're groomed, how low or high their volume is, how quickly they're speaking or slowly they're speaking, how quickly they're moving or slowly they're moving. And there are other things, but that's how we try to deduce it. However, let me say one thing. Some people cover up really well, okay? There are those, Robin Williams types who they seem really, really, not depressed, right? They seem fine. They seem happy. But they are really depressed. And so you can't always trust it, right? And so that's why you always have to ask about symptoms. You always have to ask about examples, right? If somebody tells you, as a psychiatrist, if somebody tells you about a certain symptom, I always ask about examples. How does this affect you in life? And I think that's how they could figure that out. But they can reduce you just like that. And definitely, if the meds are helping, stay on them, because meds can be very powerful. Buck Wiles, what if you are rated 100% P&T service connected? I think I probably missed maybe another comment that you had. I'm scrolling down. Maybe you had a continuation of another question. Yeah, if you're 100% PNT service connected, yeah, tell me what the follow up is for it. Oh, hit the thumbs up for everyone, for Doc, everyone. Thank you, thank you. I really appreciate it. And then another comment here, 100%. Oh man, wow, that is a great time frame. Oh man, that's fantastic. 3 days to get the decision. Definitely more rare, right? But I'm so glad. I'm so glad that I was able to help and make a change. Uh, and they listened to rational reason and evidence. Yeah, I think most people end up waiting longer. I mean, that's just the norm for the claims. But man, that is awesome. Thank you for your support. DS, both CMP and VA intake told me unless you are actively planning, it's not ideation. Oh no. I am sorry. I am very sorry that they said that. That is 100% wrong. That is 100% wrong. Oh my Lord. So unless you are actively planning, it's not ideation. False. Okay. I'm going to be like Dwight from The Office. Okay. False. Okay. If you watch that. So suicidal ideation is suicidal ideation. It is the thought of ending your life. Okay. It does not necessarily mean that you have a specific plan, okay, to do so. It is simply that ideation. Okay. You're not saying that at 2 p.m. on this day, I'm doing this. You're not, no, it's not that. Okay. So that is completely wrong. One can have suicidal ideation without a plan. When somebody tells me they have SI, I always ask, tell me more. Okay. Tell me what the thoughts are. Are there any plans? Where do these thoughts come from? Do they come from low self-esteem or what? Okay. They have to ask those questions. All right. So yeah, I'm sorry. Yeah. That's very wrong. Fleetwood mac and cheese. Thank you. You're welcome. And Manuel. Oh yeah, you're very welcome. And thank you. Thank you for your support. Okay. Mr. Mott. Hello. Thank you for being here. Yeah, you're very welcome. And I really appreciate it, man. You guys are amazing. Oh yeah. Oh yeah. Yeah. How can you contact? Let me, I'm typing, I should have done this beforehand. Prashant.sharma2@concise. Yeah, so I just typed in my email. You can email me, okay? Also on the website, www.concisepsych.com. I just put another comment. Concisepsych.com, that's the website. You can go to the medical opinions category and you can fill out my interest form, okay? Full disclosure, I do have a waiting list. I do apologize for that, okay? The waiting list is 3 to 4 months. I'm sorry, okay? It's just that the reason why it's like that is I take a lot of time with each evaluation. And so I'm slow, basically. That's why. All right. But it makes for, I think, a better evaluation. Thank you, Sivdev, for chiming in on this. There is no right answer for this. The VA will need consistency. You have to be ready to take that claim to the Board of Veterans Appeals, which is not a good answer. Rock in a hard place would be the best. Yeah, exactly. I agree 100%. And, as always, I am a psychiatrist. I'm, expert in the mental health field and evaluations. But when it comes to these more like what to do with each claim, CivDiv is the king. Okay. So remember that. I can give advice and suggestions and I can think of ideas, but he is the go-to, okay, for that. So chronic kidney disease, secondary to PTSD with alcohol use disorder. Jason Dean, 21. Very good question. So chronic kidney disease, it cannot be caused by PTSD with alcohol use disorder itself. The reason why is alcohol goes through the liver. Okay, so if you had some type of liver dysfunction, it could be connected to AUD potentially. The kidneys would be something else, but you'd have to look at the case and see, for PTSD, what medications is that person on? Are they on a medication that goes through the kidneys And could that be something that could be causing them problems? Okay. There are different medications that can do this and different reasons why people would be on them. But I would look at that. So, not the condition itself, because alcohol goes through the liver. Excellent question. Very good. Help, help the doc turn on super chat and membership. Okay. Yeah. Thank you. Thank you. I will absolutely look at that. Yep. Thanks for chiming in on this one. Okay. You went ahead and attended the CMP. Yeah. Yeah. Oh, also, when you go to the CMP exam, if you worked with me, take my medical opinion and DBQ with you. Give it to the CMP examiner. A lot of the CMP examiners, they will not get that from the VA in the package. So they need that. Okay. So give it to them. Hopefully they would use it as a reference. Okay. And a resource. If it's a virtual exam, contact the contractor, whether it's QTC or whoever. Contact the contractor and ask them for the fax number for the provider, and fax over my documents. Okay, and do that. Just some way to get it into their hands. Okay. Gino M. I just submitted my claim for mental health. Do you have any tips for when I'm scheduled? Yeah, so you submitted the claim. I'm guessing it's probably an evidence gathering, and then you'll get a CMP exam. Be yourself, okay? But emphasize what's going on with you, okay? Now, this is the tough part with CMP exams. You don't know what to say, right? And sometimes CMP examiners will not ask you all the questions, okay? And they'll say, tell me, tell me your story or something, or they might focus a lot on your childhood, okay? So you want to talk about how this is connected to service. You want to talk about the stressful incidents that you went through in service. If it's PTSD, you want to talk about the stressor events and how you felt fear for your own life or bodily injury or whatever. Okay, you want to talk about what you witnessed. Okay, and things like that. If you're doing depression secondary to chronic pain, you want to talk about the chronic pain and how the chronic pain leads you to have depression. Okay. Basically, you want to talk about how it's connected to service. A lot of folks will focus only on the impacts on your life, which is important. Obviously, the impacts are important, but you want to address the service connection first. Okay, so you want to try to focus on that. Is a BVA appeal granted cover VHA and VBA claim for the same issue? Kenneth McKinney. Great question. I have to say I don't know. Okay, I don't know the answer to this question. Again, I'm not an accredited claims agent, and I don't know all the ins and outs. So I'm sorry about that. Okay, good question. Yeah, Tim Ford, thanks for chiming in. It seems it would be better to go to the scheduled CMP exam, even if the result is a denied claim. Then it becomes a matter of weighing the negative. Yeah, exactly. Yeah, if I was applying and this happened to me, I would attend. Again, I'm not telling you what to do, but that's what I would do. Marlon, I'm the type to poke the bear. That's awesome. Hey, if it's rational and the evidence is there, why not? Hail fire. Hi, doc. Diagnosed unspecified depression secondary to tinnitus. Had CMP exam and psychologist changed. Oh, diagnosis to adjustment disorder with depressed mood and alcohol use disorder, severe and sustained remission. Right. I'm just making sure you didn't have oh, here we go. She stated that I did not identify the tinnitus as having any significant impact on mental health, which would HLR be best route? Nexus letter or journal articles were listed. Okay. Let me just go back up so I don't lose my place. First of all, yeah, sorry that happened. Okay. Unspecified depression, and you mentioned you did have a Nexus letter, right? And journal articles. So you gave them the evidence, but the evidence was not weighed correctly, right? It seems like. Yeah, I do believe that's what happened. So the evidence was there, and you don't have additional evidence, right? So yeah, it sounds like HLR again with informal conference would be the way, unless you have new evidence, okay? Unless you have new progress notes uh, showing your mental health symptoms and any connection there. But that could be a potential. So a supplemental would be if you had new evidence. So, yeah, thanks, Outlaw. I have to go, but before I do, I want to tell everyone, if you're on the fence or searching for a mental health IMO and DBQ, go no further than this, Doctor. Oh man, thank you. I really appreciate it. Oh yeah, and thank you for saying that. People, please like and subscribe. Yeah, I really appreciate it. And thank you for your support, B-Book, as always. I really appreciate it. Yes, yes. Thank you for the reminder. Yeah, I really appreciate it. All right, quantum reality. Oh man, I like that username, and I like the photo of the UFO guy. I have a question about the jamming equipment on the vehicles. I heard today that lots of gunners in the turrets develop brain tumors because of the electromagnetic radiation. I didn't get a brain tumor, but my thyroid is now out of whack. Got it. Thank you for this question. And I am going to research this. All right. I always like to admit when I don't know something and I don't know the answer to this. Okay. Because you're talking about gunners in the turrets on the Humvees, I think, or maybe something like that. So we're not talking about, well, I guess I'm not sure exactly, but let me do some research onto this and look at this. This is a very good question, especially if it's brain tumor related. I need to know. Dizzy Willow got really sick while in service, medical out for asthma because of it. Later in life, I developed really bad chronic sinusitis, rhinitis, has led to severe depression and anxiety. Navigating it. Part 1. Thank you for saying part 1 there. Pulling records to connect nasal issues, second to asthma, and connect my I'm thinking you meant, yeah, depression to that. It's been really tough, and I've been scared to try. Took the first step. Yeah, that's definitely a big journey, getting that connected. But you mentioned your medical out for asthma, so you're probably connected for asthma, right? Um, and I mean, asthma itself can certainly cause low mood and anxiety, right? Because asthma, you got to use like albuterol or maybe a corticosteroid or something like that. You can have asthma attacks that can cause a lot of psychological distress. So that can be a potential. And of course, if you connect the sinusitis, rhinitis, that would just add on. But asthma can be pretty tough for folks, and that can lead to mental health issues as well. So, Fleetwood mac and cheese is the difference, VA disability wise, between OSA and Central. Oh, what is the difference? Yeah, good question. So basically, it's the mechanism. Okay, obstructive sleep apnea is a structural issue, and then central sleep apnea is a neurological issue. So central usually happens due to some kind of neurological issue that is causing the nerves in this area and the innervation there to not be fully functional. Okay, and that leads to the apneic episodes, and that can be actually, I'm pointing here, but it can actually be in different parts. But so that's the difference there. So the mechanism is different, and the cause is different as well. Medications can cause both or either of these as well. So that's a big one. Challenge: connect GERD to nasal canal, squamous cell carcinoma. I'm thinking you meant, GERD secondary. Yeah, so this would be out of my wheelhouse. So as a psychiatrist, I can look at mental health. I can look at things that are related to mental health and some neurological things, but this would be outside. So I'm not sure. I will say, just thinking about it as a physician, there might be, because squamous cell carcinoma, maybe you got some type of radiation or chemo treatment or anything like that. And I wonder if that caused the GERD or any medications. Okay. So, Lark Bark, thanks for being here. Good evening. Angelo, I did a mental health CMP exam December 24th, which was positive for me. Now they are sending, oh no, to a second CMP. Okay. Good question. Damn. So there are different possibilities. So if something was missed in the initial CMP exam, if the rating criteria wasn't filled out properly, if there was a difference or something missing that they want to button up. So, for instance, let's say you applied for depression and the examiner identified depression, but there was some concern for PTSD. They might send you to a PTSD excuse me, uh, uh, examination. Excuse me, PTSD CMP examination. So that could be a possibility. It really depends on each case. Um, you could try and call and ask them. I know that's a big ask. That's a really difficult thing to do. But yeah. Yes, I do. I need to figure this out. Thank you. Not Jerry. Trying to get sleep apnea service connected. I did go to Dr. Weiland's service for fatigue, self-medicate. Oh, alcohol. Service connected for PTSD and tinnitus. Nexus letter worth it. Yeah, it might be. I mean, it really depends on some specifics. So your service connected for PTSD, are there medications there, right? Are there any antidepressants on board that can cause sleep apnea? The alcoholism, is that connected along with PTSD? So is it PTSD with AUD, alcohol use, or is it separate? But if the PTSD caused the alcohol use, that can also lead to sleep apnea. Alcohol weakens the upper airway pharyngeal muscles, okay, and can lead to obstructive sleep apnea as well. So those are some ideas, okay? So it depends on the case there. Clint Boston. Hey, Doc, I just wanted to tell you how much I appreciate your education, and I hope you keep up the good work. You sir, oh, man, true rock star. I hope, yes, absolutely. Thank you for the kind words, and I hope to work with you as well, and I'm going to keep doing this. All right. Lark Bark, I've had my fair share of anxiety and depression while being diagnosed with ADD. Absolutely. And those conditions, I'm just making sure there wasn't another one. Another comment. Yeah, so, and there can be overlap between symptoms of anxiety, depression, and ADD. Okay. Some people can get misdiagnosed with one or the other depending on their symptoms. Okay. Because some people will get so anxious that they can't concentrate on something, right? And but yeah, absolutely. There's a big overlap. Betty Bops, thank you for being here. Really appreciate it. Angela B, thank you for being here. Yeah, I appreciate the support. I'm glad you tuned in as well. Fantastic. Where is he located? I am located in Baltimore, Maryland, but I do my visits on video. Okay, so I've seen veterans in the Philippines and Japan and other places through evaluations. Ready for whatever. Dr. Sharma, many veterans get denied due to lack of education. I've learned a great deal, and now oh, wow. Yeah, that is awesome. And I agree. It is a lack of education. It's not our fault as veterans, okay? I did not know anything about the VA disability process when I got out in 2015. So I was in the Air Force. I got out in 2015. I didn't know this was a thing, okay? I didn't know I could work in this field either. And I didn't know for years. Okay. And it actually came up in one of the clinics I was working in where a veteran asked me for a letter. And I gave him a letter. And I had no idea how to write Nexus letters at the time. So it was only like a page and a half. And I don't know what happened. I hope it helped. But I knew nothing, so nobody tells us. So totally. Have you ever dealt with dissociative disorder or dissociative identity disorder? I believe TBI and PTSD plays a huge factor. I also think everyone really needs to pay attention and watch for it. Yeah, this is a big one. It's not as common as TBI and PTSD, but it can still happen. TBI and PTSD can play a huge factor. These episodes of disassociation, okay, derealization, depersonalization, different terms there, but different things that can happen in this disorder. TBI can do it because of the cognitive issues. PTSD can do it because of the intrusive memories and flashbacks. Okay, flashbacks can make you disassociate because you go back to that moment. So it's extremely difficult to advocate because of um, yeah. Thank you. Journaling is very good. Yeah, that's one way to record symptoms as well. I think that's a great idea. But you just do your best. You keep educating, keep advocating. You know, sorry, J Jazu 06. I've been service connected for 8 years, and I seek periodic care at the VA. I've never been reevaluated. Oh yeah, no, a lot of folks go and they don't get reevaluated. I think most folks, right? And so, and you get periodic care at the VA, and they can see that. So, it's not something I would worry about, but I would keep getting care. I would keep following up. I would keep getting documentation done. Okay. Thank you. Thank you for being here. Yeah, you just type them into the chat. I will say we're running out of time now, but I'm going to try to get to a few more questions. Thank you. Yeah, Doc, answer question in order by the live chat. Shoot, am I not answering it by the order? I apologize. Guys, I apologize if I'm not answering it in the order. Maybe I have some setting done wrong. I'm going to get this right, by the way. Okay. I'm going to figure this out. This is the first one. But M. Geik, what are your current thoughts? Yeah. So this one is very important as well. We talked a little bit about it. Basically, it's going to change into these different buckets or areas of impairments. Okay. So cognitive impairments and other areas. And it's going to take more time to come to the decision of how impaired someone is. And it's going to require a longer exam, in my opinion, which is fine with me, right? But I worry about the C&P examiners or exams not capturing the full extent of symptoms, not sitting down to grade the impairments appropriately. Okay, so, but it's going to be very interesting. I'm watching it closely. It got pushed back, as I found out from CivDiv Clay, to August, I believe. But yeah, definitely something that we have to keep an eye on. Okay. Fleetwood, I agree. Andrew Gross, he is excellent. Good evening, Doc. I have tried to schedule with you. Oh, wow. Yeah, I apologize. My waiting list was closed at one point. Yeah, you might have emailed me then. So just email me. I dropped my email in the chat, and just email me, and I'll get you right onto the list. I apologize. Okay. Awesome. Guide on Law. Yeah, there you go. That's Andy Gross. Absolutely. Strong personal statement, lay statements. Yes, I forgot about that. Those are super important. Jessica Martinson, Dr. Sharma goes above and beyond. Oh, you're amazing. Thank you for being here. Thank you for the kind words. It really means a lot. Marlon, yeah, that looks like what I have to do. I've watched. Oh, nice. You've watched her. Fantastic. Yeah, they don't write everything down. Yeah, and it's good to put that information into the personal statement. A lot of the C&P examiners, they don't ask questions, all the questions on the list as well. So, thank you. Mandibular advancement device. Okay, got it. I'm glad I answered that one. All right, guys, we're rounding out here. Can you do a case evaluation and recommendations? Oh, Mike Allen, very good question. This sounds like this is more about treatment, right? If you're talking about an evaluation of the case, symptoms, and then what to recommend as a treatment, I don't do that right now. I do full-time Nexus letters, DBQs, these types of evaluations. So not currently, okay, but I can definitely do the medical opinions. All right. What was your favorite location that you were stationed at in the past? Oh, man, that's a very good question. So I was stationed at McConnell Air Force Base in Wichita, Kansas. When I deployed, I was in Qatar at IUD. We traveled to Djibouti, Africa, Afghanistan, couple of other places. Man, that's a good question. I think I'm gonna say it's between 2 places. In Qatar, we went out in the town and we got some fantastic mango lassi. It's like a mango shake. It was wonderful. And then the other place would be Germany, where we stopped off and got beers. Okay, when I was flying. Yeah, before going to the deployed area, I would say that. All right, guys. Well, I know there's a lot of more questions in the chat here. I apologize that I couldn't get to everything, to everyone, but I'm going to do this again and I'll keep you guys posted. Thank you for being here. It means a huge, okay, this is fantastic. You guys are amazing. Thank you for the support. I'm going to save this video. It'll be there for people to review if they want, and email me if you need anything. And I look forward to seeing you guys again in the next live. All right. And I'm going to get this right. I'm going to figure everything out better next time. Okay. Thank you guys. And have a great day. Have a great night.